Let me welcome all of you to Live from Cleveland Clinic. I'm Matt Walsh, Chair of the Department of General Surgery, and I really am excited to see you all here this evening as we talk about, I think, a really fascinating topic in this current era. And we're going to talk about gut malrotation in the 21st century and what is the role of the LADS procedure. You should all know that you're joining over 400 other people from 60 countries across the world. So congratulations. We do want you to share your experiences and certainly ask plenty of questions. That's most easily done in the chat. So please feel free to ask questions of all of these experts. And I'm going to turn the program over to Kareem and his crew that he will introduce throughout the evening as they talk about this exciting topic. Kareem?
Thank you, Matt. We greatly appreciate your leadership as usual. And I thank everybody who is with us now online. And I have a lovely faculty team here. Dr. Masato Fujiki from the left to the right, Dr. Muhammad Osman, Dr. Sal Navretti, and Dr. Mekled, and Dr. Ayat El-Sharif. And I think they're gonna share with all of us their experience on the topic. And then I will kick off the program by outlining the objectives of this program, dealing with a very fascinating topic that has been neglected for more than a century. As you can see here, the first point is we're going to define the natural history and the clinical pathologic spectrum of the intestinal malrotation. Most people say it, but I call it gut malrotation. It's not just the intestine. In both children and particularly adults. Number two, we're going to introduce a novel surgical modality for the correction of the gut malrotation. It's the anatomical correction, and define the anatomical and functional defects in patients with intact gut. The third part is we're gonna emphasize the long-term efficacy of the new procedure for those who are lucky enough to maintain their gut and those who are unfortunate to lose their gut and require gut transplant or intestinal multiviscera, as we used to say it in the old days, and also the gut malrotation, the gut rehabilitation surgery, trying to eliminate the need for transplant in selected cases. And before we close our program, we'll have very unique case presentation to highlight the complexity of the topic. Let me introduce to you that malrotation is not just an anatomical term. The Latin root word for malrotation is bad or evil, and that's what the medical field ignored for a long time. I'm going to share with you, just to give a background, what happened to the gut in the embryo and during our development, and what is the rotation of the midgut. Here you can see the aorta and the gut tube, and divided for mid and hindgut based on the blood supply, celiac, superior mesenteric artery, inferior mesenteric artery. At 4 weeks of the development, the gut has to come out because the liver and the spleen and the other organs grow out of proportion. At 8 weeks, it rotates 90 degrees outside the abdominal cavity and develop a cranial limb and the caudal limb. And then the intestines start to grow and more longer. And then 10 weeks, the intestine has to come back to the abdominal cavity and rotate the 180 degrees to complete the 270 degrees we all familiar with for the organs to be in its place the way were developed. What went wrong in this journey? the journey of the gut, something went wrong to develop the malrotation or non-rotation or whatever you name it, is a deviation from the 270-degree counter clockwise rotation. And based on what we know now, there is impaired intrinsic gut innervation, what we call it the enteric gut system or the enteric nervous system. I truly believe this is a major pathologic entity associated with malrotation we all neglected over the last century. And then there is a developmental defect in the mesentery that put the organs together inside the abdomen in a fixed place, so avoid the risk of the volvulus. This is a dynamic process. It's a huge spectrum, but what we learned in the medical school, that types of anatomic malrotation, but this is only different varieties. And I will show you, prove to you, based on what I saw in the operating room for the last 20, 30 years, that every patient is different. But what we all know about the non-rotation, they call it, or malrotation, and this is what Professor Ladd find out in the kids when they have bowel obstruction, and that is we're gonna discuss it as well, and then different varieties, and every patient is different based on the time when the rotation is stopped. This is the radiologic spectrum that sometimes confuses the radiologists, particularly in the adult population. Why? Because unfortunately, the misconception that the malrotation or the congenital anomaly only happen in the kids. When the kids grow up without having the bowel obstruction or the volvulus, everybody ignored it, and they think the adults, this is a normal thing that doesn't cause any problem for them. But as you can see here, based on what I'm sharing with you in the paper we published 2 years ago, that is a wide spectrum. You can see here in your left-hand side, the whole intestine totally on the left side. Another case here. I didn't want to go through all of this, but you can see there is wide variety of the position of the intestine and colon in the abdomen. You can see this is very interesting. What I call it is a cocoon of the intestine and the duodenum on the left side. Interesting enough, in your right-hand side, you could see a case of situs inversus, and Dr. Meckler is going to elaborate on this in his case presentation. Here, we found intraoperatively wide variations in the anatomic location and the pathophysiology inside the abdomen. Here at the duodenum and small bowel, you can see this is a very common, almost every patient with symptomatic malrotation have this finding. And this is a nice art work that is published in the paper. And you see a whole variety of changes up to diaphragmatic hernia, a child who has duodenal atresia and has malrotation, the liver grow over the duodenum, and they have to fix that. And this is the cocoon, the whole intestine that placed and amalgamated together. And also, malrotation is not only for small bowel, also the large bowel has a variety of changes, in not only the cecum in the mid on the left side, it's also has a lot of variability and mesenteric attachment. Part of the anatomic variation also is the vascular inversion that we all talk about. And this is a very complicated slide, but you can see the normal malrotation or the non-rotation. You see the artery on the left of the portal vein, on the right of the portal vein, and the SMV, and the SMV on the left of the artery, to the opposite what we all know about the normal anatomy of a human being. Another interesting case, you can see here, a young lady, nobody believed in her problem, and went to psychiatric care, etc., etc. And as a matter of fact, She is very productive citizen, working very hard. And when she contacted us, I did this, as you can see, she has a chronic volvulus of her intestine, and she was lucky enough not to lose the intestine, and Dr. Osman is going to elaborate on that. The second important pathophysiology, in addition to the anatomic abnormalities, is a cause and effect. I truly believe there is embryonic maldevelopment of the enteric nervous system. We used to call the gut at the second brain, but a lot of data is coming out at actually the gut is the first brain, because with the differentiation and migration and then the maturation, the gut actually starts its enteric nervous system even before the brain fully developed. Another important problem that malrotation is not just an abnormal anatomic location of the intestine. The mesentery did not develop. As a matter of fact, Leonardo da Vinci, more than 500 years ago, had a beautiful artwork about the mesentery. The organ would never been called an organ until John Calvin from Ireland had a nice, beautiful paper in 2020. When I was searching for the disease, I said, the medical field is ignoring these patients, ignoring the pathology, ignoring everything, and living in the dark, what Professor Ladd described in 1931. Here, what Professor Ladd did a great work, and I admire him totally, but we did not understand what he alluded to. He saved a lot of kids because they have this. They have the volvulus, and they have the duodenal obstruction with the band. We call it Ladd's band, and that's what he did to save their life. But he put a statement, none of us, pediatric or adult surgeons or physicians, understand what he said. That's what he said. The condition is rare enough so that it is likely to escape the mind, but it is common enough to be important and life-threatening. We ignored what he said. Now, after 70 years, or 90 actually years, from 1931 to 2021, I cannot count because I failed in the mathematics. This paper we published 2 years ago, I'm going to show you what we showed in this paper and how this paper is so important for the evolution of the field. And that paper reflects the suffering I have with the adult patients, particularly the adult patients and young kids that who escaped losing the gut early on and have the symptoms. And that took me back to find out how many patients required transplant in my career, and there could be saved if we did this procedure for them. 500 patients from across the globe, all continents, and all of the states in North America. Here is the presentation of the 500 patients. You can see 41% lost their gut before they came to us and required transplant or gut rehab. 25% came with severely disabling symptoms. Nobody believed them. That is due to the malrotation. The radiologists make the diagnosis. The clinician doesn't believe the malrotation causing their symptoms. And then 34% from our database have malrotation, had Ladd procedure, good number of them, I will show you the percentage, and was diagnosed due to radiologic or operative finding. Here, what is the role of the history of Ladd procedure? Professor Ladd did not develop the procedure to treat the disease. He developed it to treat the obstructed duodenum in the newborn with volvulus, and he saved their gut, some of them, when he opened them at enough time to save the intestine from becoming gangrenous. Look at the 500 patients. 192 had the Ladd procedure, 38%. 25% of the patients who lost their gut before they came to us for a transplant had lead procedure at newborn. And 60% of those who had disabling symptoms, searching for somebody to help them, had lead procedure. Those who be asymptomatic have vague GI symptoms and they didn't know why, had lead procedure when they were newborn. Based on these 500 patients, we were able to develop what I call gut malrotation syndrome. It is not anatomic anomalies, it's a syndrome. And these are the patients who were lucky enough not to lose their gut. Here are their symptomatology: severe pain, bloating of the abdomen, nausea and vomiting, constipation alternating with diarrhea, pelvic floor dysfunction. And that supports my notion that it is not just anatomic anomalies, it's a neuroenteric disorder, neuromuscular disorder, in addition to the failure for the mesentery to develop to avoid the risk of volvulus. And we utilized well-established scales called NIH Probus Gastrointestinal Symptomatology Scale. Based on this, we developed a predictive model to define the syndrome. As you can see here, this is the probability and for each symptoms, and we find out abdominal pain, bloating, nausea, plus or minus vomiting define the gut malrotation syndrome. Now, the last part of my topic is what is gut malrotation correction surgery? You can name it anything you want, but this is the therapeutic goal, is to alleviate the patient who maintain their gut and they have the severe gastrointestinal symptoms, and B, or two, to prevent de novo or recurrent midgut volvulus. This is an example of a week ago, a 28-year-old young man had lead procedure when he was newborn baby and had recurrent abdominal symptoms, put a gastrostomy tube in him, do this, do that, and they missed the whole idea was chronic volvulus. He was lucky enough to go to a competent surgeon trying to find out the problem. The anatomy was very confusing, and he contacted us. We brought him in, immediately air-flighted him, operated on him. This bowel was already gone, but we were able to save about half of his intestine and the colon, and he's fully recovering now. And that is just, you don't want, as a surgeon, as a physician, as a father, as a mother, anybody, any human being, you don't want to see this ever. How can we prevent this from happening? Is to do the correct operation. Here are the surgical principles quickly, and my colleagues is going to share with you their experience with the open and laparoscopic surgery. We have to complete the embryonic 270-degree rotation. 90 degree already happened, and most of all of the patient, we have to complete the 180 degree, as is going to be described to you in the operating room. And we have, because of the mesenteric attachment did not develop, we have to do it surgically. And those who have severe colonic dysmotility, which about half or less than a half of the patient have progressive colonic dysmotility, and you have to resect part of the colon. Is it because convoluted? And if you do more and more of these cases, you will see there is a mesenteric defect or developmental defect with very contracted mesentery of the colon. It's not just the root of the mesentery. It's a disease of the whole gut. Here, my dear colleagues, or I call him my Japanese son, Dr. Masato Fujiki, is gonna show you some video about and the outcome of the open surgery. Dr. Sal Navarrete just joined us recently, and he's mastering the technique of the laparoscopic correction or complete correction of the lead of the malrotation. All right, and here is the irrefutable dispute that in your left-hand side, 2 or 3 of pediatric surgeons put this paper in the pediatric surgery journal, and they're claiming that whatever I published in the Annals of Surgery and presented in the American Surgical Association is going to put them liable if they don't do the procedure for patients who develop volvulus. Dr. Osman is going to show you, even at the age of 80 years of age, that procedure 2 weeks after birth, 80 years later, the patient developed volvulus and lost the gut. And that is what we answered them, that we really work to good at the community. Pediatric and adult surgeon has to be aware of the malrotation. It's a syndrome. It is not just anatomic anomalies. And as you can see here, there is a recent paradigm shift. You can see here, one of the pediatric surgeons did the first case and well illustrated within the news in Spain. And he put in his diagram the LADS procedure and our procedure, trying to spread the knowledge about the new operation to prevent the development of volvulus and to alleviate most of the symptoms of the kids and the adults. And that is the paper is published, I think, a few weeks ago by Dr. Javier Bueno. And also our colleague, Dr. Giuseppe D'Amico, did 2 cases in Italy. And this is the first case. A nice lady was him with in the photo there, and one of his Italian hospital and his colleagues there. That's from South Africa, and actually she recovered 3-4 days. She was out of the hospital there, and she actually contacted me a few days ago. And another case from France, we didn't have the approval from her to present her case. And I thank you all, and I hope I didn't take too much of your time. And I'm gonna introduce my colleague, Dr. Masato Fujiki, to share with us his experience in the operating room with the open technique. Masato is the director of our intestinal and transplant program and leader in the field. And Masato, the floor is yours.
Thank you, Dr. Karim, for great introduction and whole through presentation. We all here very excited to be here to present our experience to audience all over the world. My role today is to present this open surgery technique of new corrective surgical procedure utilizing a video clip in the middle of my presentation. So we already discussed that, but this presentation and the diagram was presented 70 years ago by Dr. William Snyder in the ASA meeting, actually here, Cleveland, Ohio. So basically, the patient with malrotation didn't have this embryonic gut rotation in the face of the fetus. Therefore, our procedure will complete this embryonic rotation in the operating room and fix this mesenteric to the surrounding tissues. And 30% of the patient of ours has concomitant gut dysmotility, colonic inertia. Then we also perform the limited colonic resection in those patients. So this diagram showing our typical patient, even though after the last procedure, the duodenum was dilated because of the kink and adhesions in the first part of the jejunum and the end of the duodenum. And importantly, the left side colon was also there and redundant, close to each other, adhesed. And sometimes it's wrapped by the omentum. So these things are also need to be addressed in the operating room. So I'm going to show you the video. So we're going to move quickly here. So here's a video clip. The first, we're going to inspect abdominal cavity. The small bowel is on the right side, and the left side, the redundant colon. Then first of all, we have to mobilize this small bowel and significantly adhere each other and the retroperitoneum. And this is not seen in the normal anatomy patient, and the colon is also mobilized. So at this point, very importantly, this is a typical sign that the first pass of jejunum is very kinked, bent. So therefore, we have to spend some time to release this kink by releasing these adhesions. And commonly, we see adhesion on the right upper quadrant, especially patients who had gallbladder cholecystectomy. As we can see that we spend some time to release this membrane to release the kink of the small bowel. Here, important picture, SMV is on the left side and SMA is the patient the right side. This is completely opposite to the normal anatomy. Now this duodenum is ready to be rotated. Now we align this to the second part, third portion of the duodenum, and now fourth portion of the duodenum crossing the midline. And it looks like now it's normal anatomy. So now this triad ligament is newly be created. So this patient had a redundant segment of the colon like this, and we decided to perform a limited colonic resection. And again, we perform like 30–40% of the patient. Then we attach the left side to create a new splenic flexure. Then we perform a duodenopexy, starting from the second portion of the duodenum to retroperitoneum, and go down to third portion. Then we create a new triad ligament in the DJ junction on the left side. And the colopexy is performed on the right side by putting suture from the between cecum and the right abdominal wall. And finally, we're gonna fix this mesentery to retroperitoneum to close this defect to prevent internal hernia. So this is the last picture. So after surgery, you can tell the small bowel on the right side is now relocated left side. SMV was left side, SMA was right side. This was to the correct position. So this is a summary of operative data and the hospital course. Operative time is 7 hours, not so short surgery, but with minimal blood loss. Length of hospital stay is 13 days. Some of patient has persistent, little bit slow recovery of the duodenal function and stomach, but the complications are limited. Severe complication was limited to 4%. So this is symptom scores on the total patient population, 74 patients, after this corrective surgery in the all GI symptom domain were significantly improved. And when we look at the patient who had the latter procedure before, in the 34 patients, these patients are seeking for help after latter procedure. So therefore, they're a little bit biased, the patient population. So these patients all had some persistent symptom even after latter procedure within the all GI symptom domain. But after this gut malrotation corrective surgery, these symptoms are also improved. When we divide the patient who has gut dysmotility in 53 and without gut dysmotility, even with gut dysmotility, by performing limited colonic resection, we see some significant benefit by this surgery with a significant improvement of the GI symptom in the all domains. Lastly, this graph shows that nutrition performance after the surgery, and the 13 patient was on TPN before the referral because of severe GI symptoms. However, after the surgery, this patient all weaned off TPN without losing weight, BMI, and performance status significantly improved. So here's my conclusion in my part. This introduced a new technique, mimics embryonic mid-gut rotation, and the procedure is technically feasible and effective therapeutic modality, especially after the patient who continue to have symptoms after that procedure. And now the procedure is now ready to be reproduced in anywhere in the world, and possibly by minimally invasive approach, which Dr. Navarrete will talk about. Thank you for your attention.
Thank you, Masaru. Sal?
Good afternoon. Thanks, everybody, for being present. Special thanks to Dr. Walsh, because he was the one that made this connection between the intestinal team and myself. Thank to Karim for letting me be part of this and try to reproduce his technique through a minimal invasive approach. So in terms of the selection criteria, we're treating symptomatic adults with malrotation. Prior surgeries, it's a partial contraindication, especially if those interventions were in the GI tract and if they were open. We still try, and if we find a lot of adhesions, then we convert it to open if we need to. Body mass index, we found that BMI higher than 35, it makes the procedure more difficult. There's a lot of intra-abdominal adipose tissue. Patient preference, of course, we discussed with the patients that we started this technique in December of 2022. We've done a few cases, and we, of course, give the options of the patients to decide between the open versus the procedure, the laparoscopic approach. So far, all of our patients, all 6, has been type A malrotation, as Karim was describing as the more commonly performed one. In terms of the surgical technique, it has been discussed. We reproduce exactly the same technique that it's done open. We do a diagnostic laparoscopy, duodenal dissection with PEXI. We complete the anti-clockwise 180-degree malrotation. We create a new ligaments of trites. We PEXI the mesentery. We do colonic resection when it's indicated, and then we reframe the colon by PEXIing into both sides. This diagram was shared already by Dr. Fujiki. 5 steps again: duodenal dissection with complete cockerization and free up of the first jejunal loops, counterclockwise rotation with duodenopexy, recreation of the ligament of trites, mesentericopexy, and then reframing of the colon. This is a picture of one of our patients. We use basic laparoscopic equipment, a harmonic scalpel in this case, and a monopolar device, 4 5s and 1 12 trocars. The right lower quadrant trocar can be upsized to a 12 in case we do the colonic resection. The patient will go and modify lithotomy. This is a surgery that works in 4 quadrants. So by having the patient in lithotomy allows you to rotate from the right, left, and between the legs. So it's, it makes it a little bit easier. And also, if you're going to do a sigmoidectomy, then you're going to need access to the anus to do the anastomosis with an EA. In terms of the perioperative management, these patients will go an NG tube and a Foley. Some of them get an A-line depending on their medical conditions. Here we're going to start with the first clip. This will entail the first part of the diagnostic laparoscopy. We can see how the intestines, it's on the right side. And then we are going to start dissecting the first loop of jejunum and the convoluted duodenum to the head of the pancreas. We start with a medial dissection. We use the harmonic scalpel for this. It's an instrument that, allows you to do a fine dissection. It's very safe. We also dissect laterally. It's surprising, the difference when you see this on the CT scan. You never think about how convoluted it is, how folded it is over itself until you do the surgery. And as we can see now, the more you dissect, you think you are done, and you still have folds and folds of this duodenum. So now we're doing connecting the ducts from the lateral side to the medial aspect of it. We're being careful, of course, not to injure the serosa. The harmonic is an instrument that, gets very hot at some point. So we continue dissecting. Sometimes, if we feel, the harmonic can be too hot for the tissue, we use sharp dissection, as we're going to see on the next clip. And again, as I said, it's more folded and convoluted that I never thought. We continue doing our cauterization. We're working above the cava right there. And then we continue that dissection until we expose the left renal vein. And once we are there, we start our duodenopexy. We're going to see on the next slide. So we do interrupted non-absorbable polyester. In this case, this is 3O with an SH needle. We go behind the duodenum and we're pexing it just to reproduce that flat normal C loop. And once we took all the adhesions down. Okay, this picture is just to orient the attendees a little bit because it can be confusing. On top is the head of the patient, bottom are the feet. Right side of the screen is left side of the patient. Left side of the screen is right side of the patient. This blue circle here, it's the huge retromesenteric window that these patients have, right? That's where the internal hernia can happen. That's why the volvulus happen. In a normal patient, all the root of the mesentery is attached to the pre-aortic fascia right here. This is the aura on the left, and behind that is the cava. That yellow semilunar line is where the new tract is going to be. We can see the root of the mesentery on the left side of your screen, and this is the IMB on the right side of the screen. So here's the clip that we're going to see how we do the 180 anti-clockwise rotation. So we're going to start pulling the intestine from behind. We can see the cava right there, the iliac division a little bit lower than that, but so we're going to continue pulling the bowel. This is probably one of the more challenging parts of the surgery. Sometimes, if the patient has more adipose tissue in the abdomen, it's a little bit harder to manipulate the mesentery. So once we have the area of dissection that we did from the other side, we know on the right side, you can see how the intestine is laying flat and nice there. And we start putting the stitches from the D4 or a new D4, that's the IMB right there, to the pre-aortic fascia. So we continue doing that. That's anterior. You can see that lymph node that belongs to the periaortic chain. It's important to get the stitch right there where the dissection was, because that tells you you are at the posterior aspect of the D4 or the new tracts. Okay, we advance a little bit. This is another stitch. And here we're going to see this is the first stitch of the retromesenteric window closure. We can see that we're on the back part of the mesentery, and we're putting that stitch right in front of the iliac bifurcation. This is the first stitch. So we keep going. This is a complete change of gears. Now we're working from the left side of the patient to the right side of the patient. We can see the psoas muscle right there, the right ureter in front of us. And this is the duodenum that was already pexied, that is going to stay behind the mesentery. And we're going to continue doing our closure of the mesentery. We can see now how the cecum is in the right spot. You can see also the appendiceal stump there. We already did the appendectomy in this case. And we're going to continue closing that space as it was explained on the diagram. Thank you for Dr. Fujiki for explaining it so well. So we continue one by one until that space it's completely closed. Again, we're going to see at the end how the mesentery is closed. We have interrupted stitches, TI in the right spot, cecum in the right spot, reproducing the diagram. In terms of the colonic resection, this has been said before. depends on how it looks intraoperatively. We do or don't do colectomies. We can do a right, we can do a transverse resection, we can do a left, or a subtotal. I haven't had the opportunity to do the subtotal so far. And again, this is a clip showing how the intestines is again on the right. And we're going to see how the cecum is just, well, this is the psoas, I'm sorry, on the right side. There's no cecum. And then we can see the cecum that it's in the pelvis. It's completely redundant. And what we're going to do is bring it up. You can see that it's on the left side and flip it to the right side in the regular position. This patient allow us to do it very well because the colonic mesentery wasn't so that retracted. Sometimes it's so retracted that you can do this. And then we can see how the left side has an N shape, as Dr. Fujiki was saying before. So one of the keys is that to liberate that colon completely, so it needs a medial dissection, a lateral dissection, and a completely detachment from the omentum in order to be able to reframe it without tension. So we can see how we go lateral completely until we expose the left kidney in this case and the tail of the pancreas. And then we continue our dissection. Once we have it completely free, we start our cecopexy on the right side, right there. And we want to just go right where we start our dissection, make sure we're on the right spot. And we, again, with interrupted suture, non-absorbable, of course. There's ethibone. I feel ethibone, it's a little bit easier. So once I convince Dr. Abu Elmak. And then at the end, when we need it, we do a transection of the sigmoid. And, oh, I'm sorry. And we finish with an end-to-end colocolonic colorectal anastomosis in the standard fashion. So far, we've done 6 patients. Standard post-op management, all these patients go to the floor with a nasogastric tube and a Foley catheter. We start PO intake once we have return of bowel function. We remove the NG, and these patients go home on a regular diet. We've been able to complete the complete laparoscopic procedure in 5 out of 6. One of the patients had to be converted because she had higher BMIs. The mean operative time has been 322 minutes, which is about 5 hours. And the shorter case was 3 hours, and the longest case 6 hours-ish. Length of stay, the mean has been 7 days so far. One patient left after 3 days, and the longer patient stayed for 2 weeks. It's a patient that had a very prolonged bilious. One main adverse event was one deep surgical site infection. And as I said, one patient with prolonged bilious. In terms of the follow-up, these patients are being asked or run through a questionnaire that was described by the NIH in American Journal of Gastroenterology in 2014. So we modified a little bit for this pathology. So we're running this at 6 months and a year after the surgery. So far, these patients, the main complaint of these patients is nausea and abdominal pain. 40% of them presents with severe constipation as well. And so far, the reports that we're getting is there's an early resolution of the symptoms. It's hard to tell yet. We need longer follow-up, of course. The longest we have is 10 months. The first case we did in December 22nd of last year. But we continue to follow up these patients to see what's the result of the laparoscopic technique. Of course, so far, we feel, the procedure is safe, it's feasible. And then our mean operative time, it's a little bit shorter than the open portion of it. I think it's because our N still low, but definitely the length of stay is shorter with the laparoscopic approach. Thank you so much.
Thank you very much, Sal. I learned more from your talk today than in the operating room. And you've done a great job, and I'm so proud of you. And I think I thought early on that he may not be able to do it without a new new instruments, but you proved me wrong. And although you gave me a hard time in the first few cases in the operating room, but I'm so proud of you, and the patients are very happy. As if the last patient we did, I think we had a virtual visit with her today. She's doing remarkably well. Now we're gonna move to the case presentation. We have Dr. Muhammad Osman, who is a central figure in the gut transplant and rehabilitation center here. And he's gonna talk to us about a very interesting case of chronic volvulus. And the patient was lucky enough, a young lady, lucky enough not to lose the gut. And physicians never pay attention to her symptoms. And Dr. Osman, share with us your experience with this, and also he's going to elaborate in the mid-gut volvulus and the life-threatening consequences could happen when the patient loses their gut.
All right. Thank you, Dr. Karim. Thank you, Dr. Walsh. Thank you for everyone who's joining us either tonight or morning or evening or afternoon based on where you guys at. All right. So I'm going to talk today about volvulus with gut malrotation. So I'm presenting a case, a 35-year-old female patient, BMI of 18. She was not on TPN. She didn't have any previous surgeries. And she presented to us with chronic abdominal pain, recurrent nausea and vomiting, and chronic partial bowel obstruction. Patient also had multiple visits to the emergency room for partial bowel obstruction, and those bowel obstruction episodes were treated conservatively. So those CAT scan images at referral to us, this was in July 2023. So you can see the mesenteric swirling, and because of the chronic volvulus, this patient actually had chronic SMV thrombosis. So you can see here in this image the portal vein is patent, and those are the venous drainage of the intestine, and then the SMV is chronically narrowed and thrombosed. So we performed CTA before surgery, and interestingly, you can see the spiral distribution of the mesenteric arterial branches, which obviously show the evidence of the chronic volvulus. So we took the patient to the OR. This was in August 4th. We did the gut malrotation correction surgery. In this image, you can see this patient had chronic volvulus with viable intestine. And in this picture, you can see that because of the chronic SMV thrombosis, the intestine is draining through large collaterals, and those collaterals are joining and draining through a main collateral alongside the right colon and cecum and right colon. So again, we did the detorsion of the complete chronic volvulus. We did the correction of gut malrotation, and we created the new ligament of Triads as prescribed by my colleagues before. We did partial colectomy. Of course, we preserved the cecum and the upper part of the ascending colon to preserve the venous drainage of the intestine. And then we performed colocolonic anastomosis, and we did the PICCs. So current status, so actually patient is doing really well. This follow-up after 2 months. I actually talked to her like a few days ago, and I know she's registered to the meetings. She's probably listening. She's actually have an unrestricted oral diet. She's gaining weight with complete resolution of the preoperative symptoms, and there are no visits to the emergency room after our surgery. So again, as Dr. Karim mentioned, this is our experience with 500 patients with gut malrotation. So I'm going to go just briefly over the cohort. So 500 patients, 55% of the patients were children. 59% of the patients presented with intact gut, while 41% of the patients presented with mid-gut loss. Of course, you can see here that majority of the patients who presented with mid-gut loss were children, 174 patients, and volvulus was the leading cause of mid-gut loss in about 97% of the patients. So patients with mid-gut loss mainly treated with gut transplantation in 174 patients. So there's about 92% of the patients. Again, LADS procedure was documented in 192 patients, as Dr. Karim mentioned earlier. Gut malrotation correction procedure was performed in 80 patients, which is 16% of the cohort. So this slide shows the volvulus history and distribution among the study group. So 500 patients, 254 patients had volvulus, 51%. So of those 254 patients of volvulus, 198 patients were presented in the mid-gut loss group, 78%, while 56 patients, 22%, were presented in the intact mid-gut group. So those are other associated congenital gut anomalies that also can lead to mid-gut loss. You can see gastroschisis, omphalocele, duodenal and jejunal atresia. So this slide actually showing the volvulus mid-gut loss in relation to age. So the first chart here, it's showing that about 64% of mid-gut loss happened during the first year of life. But also for the intact gut group, you can see that they present with chronic symptoms, and those symptoms actually worsen over time. And in chart B, the red dots actually represent the volvulus history with catastrophic gut loss. So you can see also cluster of mid-gut loss happening during the first year of life. But if you follow, you can also see that some patients lost mid-gut around 70 years of age. So this is a mid-gut loss predictor, which was performed through a multivariate analysis. So the volvulus was a major predictor factor to develop mid-gut loss with very high odd ratio, while LADS procedure and increased age were actually lower risk to develop mid-gut loss, but they did not prevent the mid-gut loss from happening, which is a very important point. So this is also a cumulative risk of mid-gut loss till 80 years old. So this graph, you can see that volvulus, no volvulus. So volvulus history increased the cumulative risk for mid-gut loss. And this graph, you can see patients who had LADS procedure, 192 patients in blue, and patients who did not have LADS procedure were about 308 patients. So cumulative risk was higher, of course, in patients who did not have LADS procedure, meaning that LADS procedure was protective to some extent, but did not prevent the volvulus or mid-gut loss from happening. And to summarize, so gut malrotation is a clinical pathological syndrome affecting all ages with wide array of gastrointestinal symptomatology. Volvulus development is the leading cause of mid-gut loss with gut malrotation patients. Gut transplantation remains the life-saving procedure for patients with mid-gut loss. Surgical correction is the line of treatment for gut malrotation syndrome for patients with intact midgut. LADS procedure has protective effect but did not prevent volvulus recurrence. Gut malrotation correction procedure managed to improve all symptomatology domains without a single case of de novo or recurrent volvulus. And lastly, vascular anomalies awareness is crucial to avoid catastrophic surgical complications. Thank you so much.
Thank you very much, Dr. Osman. Wonderful,
Thank you.
wonderful work. And I just want everybody to know all these efforts and all what we introduced or put ahead for the field is a effort of multidisciplinary group efforts, team efforts, as you can see. And I'm proud of all of you, and this will never happen without the mind and the time and surgical skills of all of you. The next speaker, and just let the audience know, I'm not very good with the chat, but at the end of talks, then I will highlight some of the questions in general. I'll answer some of the questions to all of us. Now, Dr. Ayat Al-Sharif, which she's our clinical research fellow, she's gonna talk about very interesting case that we were lucky to help her in our home country, Egypt, while we're developing this procedure. Ayat?
Good evening, everyone. Thank you, Dr. Karim, and thank you, Dr. Walter. So our next case, we like to call it the inconceivable presentation. It's a case of one-year-old female who was born with a huge oxonphilus that was neglected since birth, and there was no history of prematurity. And due to the lack of the complex cases expert in Egypt, the case was treated conservatively for over a year by frequent repeated dressing. Her family has seen many surgeons for her condition, and all of them declined to operate. And then they tried to connect with Dr. Karim through social media, and it was arranged that he will see the patient in one of his visits to Egypt. At referral, as you can see here, the clinical presentation is a very huge omphalocele with skin maceration. Her abdominal X-ray shows that there is an intestinal loop in the exophilus. The abdominal ultrasound and Doppler, it showed that the presence of liver and the bowel loop in the exophilus major, with a patent vasculature in portal vein. The CT confirmed the presence of the right liver herniating from the anterior abdominal wall, and it has normal density and normal size. And as you can hear, this is the patent hepatic vein. Preoperatively, we did, her labs were normal except for the SGOT was slightly high. We did an echocardiogram to exclude the cardiac anomalies, and her chest X-ray was clear. We also took the measurement of the omphalocele and the defect to assess if we will need a rotation of that. Then the surgery, we did reduction of the abdominal organs, correction of the gut malrotation with the creation of the neoligament of Trides, appendectomy, cecopexy, sigmoidopexy, and mesentercopexy. The most important thing to be cautious about in such surgeries is to avoid the development of compartment syndrome and to avoid the kinking of hepatic vein or splanchnic vessels. Post-operatively, the recovery was uneventful, and she left the hospital after 2 weeks. These photos show the stages of the wound healing. The first one was after 3 months, and this after 6 months. And here when the wound was completely healed, and this is the shape of the scar, and this was after 3 years. Currently, we are 6 years after surgery. She has full nutritional autonomy, gaining weight with excellent quality of life. So what are the common congenital anomalies associated with malrotation? Biliary atresia, congenital diaphragmatic hernia, atresia or stenosis of small intestine. In our 500 case study, the incidence of atresia was 10%. Other causes are the transit cystic fetal mass, duodenal web, gastroschisis, Hirschsprung disease, and perforate anus, intestinal pseudo-obstruction, Meckel's diverticulum, omphalocele, and pyloric stenosis. There are also some syndromes that are associated with the malrotation, as the apple peel intestinal atresia, Marfan syndrome, chromosomal trisomy, heterotaxy, mobile-second syndrome, Brown belly syndrome, and Verdun syndrome. In our studies, the genetic syndromes consisted 13% of our population. So what's in the literature about the association of malrotation with patients who have omphalocele? This is an 18-year study that was done from 1991 to 2009, where 42 infants were included. They had exomphalus major and exomphalus minor. And it was found that the incidence of the surgically confirmed malrotation was 45% in the patient who had exomphalus major and 31% in the patient who has exomphalus minor. Another study, which is a systematic review that was published in 2018, and it was done on 111 articles were analyzed, and in 12 articles reported that the malrotation was found in 136 patients, or 3.5%. And malrotation was equally found in the exomphalus major and exomphalus minor, where percentage in the major was 15% and in the minor was 13.6%. The authors concluded that although the incidence seemed low, but it's probably because it's underreported, and they found that it's not influenced by the size of the concerning the staged repair of a giant omphalocele in the neonatal period. This study confirmed that it's feasible to do staged repair in the neonatal period without opening the amniotic sac. However, intestinal malrotation should be excluded first. Concerning the risk of midgut volvulus in the patient who has abdominal wall defect, this is a multicentric study. It was done in 3 institutes. It was done between 2000 to 2008 for the patient who carried the diagnosis of gastroschisis and omphalocele. The authors found out of 413 patients, there was 8 patients, or 1.9%, who suffered from a midgut volvulus. And the incidence of midgut volvulus was significantly higher in the omphalocele population than the gastroschisis cases, where it was 4.4% in the omphalocele and 1% in the gastroschisis cases. So what are the takeaway message from this case is that the association of malrotation in exomphalus infants is alarmingly high, which supports the need to actively exclude the abnormality either operatively or radiologically. Also, during the repair of the liver containing exomphalus, we have to avoid the kinking of hepatic vein, splanchnic vessel, or the development of compartment syndrome. And patients with omphalocele have a greater risk of developing midgut volvulus, which warrant the prompt repair of omphalocele. And thank you.
Thank you very much, Ayad. I think it's still a very interesting case, and still, thank God well that this girl is doing very well. And I still can't imagine that we're able to put all the organs in, including the liver, without any problem. And she's in school doing very well. Our last case presentation is Dr. McLeod. Is going to talk to us about the whatever bursitis and bursitis ambiguous. It's still confusing for me, but all I know is this: the organs are not just the intestine. A lot of organs inside the abdomen and chest, so they wrongly placed, and that actually confirmed what I have in mind. If you look at all these organs migrate from different parts during the embryonic development, and sometimes they lost their way because there was no GPS for them to go to the place that they're supposed to be. Dr. McLeod. Dr. McLeod is our new faculty that joined us a few months ago, and I'm looking forward to hear his presentation.
Thank you, Dr. Karim. Thank you, Dr. Walsh, and hosts, and all the speakers and the audience. Okay, I will talk about the gut malrotation and the ambiguous anatomy. What is ambiguous anatomy? So there are 3 types of visceral arrangement. The normal arrangement with the unique right and left concordant structures, like the liver on the right side and the stomach spleen on the left side. And if the visceral arrangement is abnormal haphazardly, it's called situs ambiguous. Like you see in this picture, the stomach is on the right side, and there's the spleen on the right side with polysplenia, like the patient I will present very soon. And situs inversus is exactly a mirror image of the normal anatomy of abdominal and or thoracic organs. The incidence of this is very rare. Situs ambiguous is 1 in 10,000 newborn, and situs inversus is 1 in 8,000 to 1 in 22,000 birth. The gut malrotation is seen in 70 to 100% in situs ambiguous patients in the literature, and multiple reported cases of gut malrotation associated with situs inversus as well. In the paper published by Dr. Abul Magd in 2021, there was 80 patients that underwent the gut malrotation correction procedures, and 2 of them had ambiguous anatomy. So percentage is 2.5%. So I'll talk about the first case. She's 50-year-old African-American female, referred in February 2021 with symptoms of recurrent severe abdominal pain, several ED visits since childhood, recurrent nausea and bloating, marked constipation alternating with diarrhea. The patient was diagnosed of situs ambiguous in 2001 by a CT scan. Her BMI was 41 kilogram per meter square, and her abdomen was distended on clinical exam. For preoperative workup, her labs were on normal values. We did an echo to exclude cardiac anomalies, and it showed normal ejection fraction. Her CT chest showed that both lungs are bilobed, and the right bronchus is identical to the left bronchus, which is common in the situs ambiguous cases. Her abdominal CT scan, as we see in the axial cut here, we can see the polysplenia with the splenic vessels. We can see the right-sided stomach, and this red arrow is on the left-sided IVC. And in the coronal cuts, we can see very clearly the left-sided IVC and right-sided aorta inverted. In her contrast studies, we can see in the upper GI series, we can see the stomach in the right side, and we can see the colon gas on the left side. And in the contrast enema, we can see the colon looped in the left side, is classic malrotation. We did also motility studies before the surgery. She cleared her SITS marker on day 3. And she had normal gastric emptying to solids. She underwent the procedure in April 27 of 2021, and this is the intraoperative finding. We can see the right side of the stomach and the liver with the congenital anomaly. So the correction of the malrotation was done in exactly a mirror image of the standard technique that was described by Dr. Fujiki very well. The patient also had right-limited hemicolectomy because of her history of constipation and the mesenterocopexy, colopexy, and sigmoidopexy. Now patient is 2.5 years after surgery, with unrestricted oral diet, with excellent quality of life, with resolution of all her symptoms, and she is in the news talking about how the surgery changed her life. The second case I'm going to present is a case that was done in Egypt. She's a 44-year-old Egyptian female pharmacist referred in 2019. The patient has severe constipation, abdominal pain, nausea, vomiting since childhood, and also was her abdomen was distended on clinical exam. Her pre-op workup also, she had the normal lab work. Her echo showed no congenital anomalies, and CT chest showed no abnormalities. And I'm showing here the cardiac apex is to the left side, so she was levocardia. Her CT scan, we can see the right side of the stomach and the left side of the liver, completely a mirror image of the normal anatomy. And in the other picture, we can see anterior portal vein, and the pancreas is on the right side. Contrast study, we can see here the right side of the stomach, and we can see that the duodenum didn't cross midline, and you can see the small bowel is amalgamated cocoon-like picture that was described by Dr. Karim in some of his cases. She had delayed transient time of the contrast, which goes with her this motility. Intraoperatively, the procedure was done in April 29, 2019, and we can see here the anterior preduodenal portal vein and the liver, the right lobe of the liver on the left side completely inverted, as you can see here in the CT scan. So for the surgery, the correction was done in a mirror image that was described. The adenopexy was done on the left side, and the new ligament of Treitz was created on the right side, and the mesenteropexy. The patient had the subtotal colectomy because of her dysmotility and severe constipation. And now the patient is 4.5 years out with unrestricted oral diet, and she had improved quality of life, but the patient had intermittent constipation from global dysmotility. In summary, congenital gut malrotation should be associated, can be associated with other abdominal and thoracic anatomic abnormalities. Pertinent imaging are very essential to guide the safe performance of the gut malrotation correction surgery. The surgery is safe and technically feasible utilizing the mirror image approach. Thank you so much.
Thank you very much, Dr. Macklin. Wonderful, wonderful talk. I'm so proud of your presentation. It was very helpful and shed a lot of lights on this complex patient that sometimes very difficult to go in the abdomen without knowing the vascular and organ anatomy. And for all of our audience, that the door is wide open here at the clinic for both physicians, surgeons, pediatric and adults, and also for the patients to contact us. We're doing at least one case a week, and the team is welcome any surgeon who wants to come and observe, because this procedure, I truly believe, that must be offered to both adults and children. And also we need to spread the word that malrotation doesn't end on the first year of life. Malrotation stays with the patient until 100 years of age. And we have to, when the patient have symptoms, we really have to correlate their symptoms with the radiologic diagnosis of malrotation. We cannot just tell the malrotation in adults doesn't cause any symptoms. And this is the misconcept that we are trying to really eliminate it from the medical books. I think this is a syndrome. I think it's not just anatomic anomalies. And I just want to talk about it again and again and again, because we need to change what they taught us in the medical school. This is not just anatomic anomalies. The patients they witness a significant improvement in their symptoms, and there is no way that I can emphasize how important for us to increase the awareness about the syndrome and the symptoms that we have to seriously consider to change the life of these patients and protect them from from having a catastrophic event that would change their life forever. There were some questions that I answered on the chat, and just we are available all the time. My cell phone is everywhere on the internet and WhatsApp, and would be more than happy to host any surgeon or physician want to come when we have a case. Laparoscopic, open, pediatric, adults, and that is we're here for. That what we were able to develop. We want every single patient with the syndrome or with the malrotation to benefit from that product. In closure, I think we want to emphasize the take-home message. Number one, the pathophysiology of intestinal malrotation or gut malrotation, it's not just anatomic anomalies. It's anatomic anomaly, the cause and effect of the maldevelopment of the enteric nervous system from mild to severe, and the lack of the development of the mesentery, which is this sinister problem that lead to the development of volvulus and mid-gut loss, which change the life forever. Two, the new procedure, as all the speakers said, can be done open or laparoscopic. And I expected the laparoscopic technique to develop within a year or so, and I put this in the 2021 paper. And I'm glad that Sal proved me right. And I think whoever laparoscopic surgeons can do it in their way, and the surgeons who are familiar with open surgery, they do it in the open surgery. And the procedure is technically feasible, no fear. There was a notion that people thought that we cut the blood vessels and rearrangement. That's not the case. We're just doing the 180-degree anti-clockwise rotation. All the vessels goes into normal anatomy without touching them. Complications are minimal to none, and the technique could be mastered in no time by pediatric surgeons or adult surgeons who are interested to help with their patients. A lot of patients, as you can see, that with the LAD procedure, the surgeons open them and they said, oh, well, there's no LAD. There is no LAD, you don't have to do anything. That is not, that has to change. We have to correct the problem based on the techniques we just shared with you. There was also notion among pediatric or neonatologists, and I get a lot of calls from moms of newborn baby who was born in utero with mid-gut volvulus. And as we emphasized in the paper, some of these kids who have mid-gut rotation or intestinal malrotation, they could develop volvulus in utero. And this, with the advances in the uterine surgery, these babies could be saved. If not, and there's no circumstances to help them based on the location and the hospital facility, that these patients, if they lose their gut, they are candidate for transplant and gut rehab. I advise the neonatologist and pediatric surgeon, don't leave the intestine dead in the belly for the baby to die. Take the intestine out. We have the advances of intravenous nutrition, and we can transplant to these patients at a later age. As you can see, the outcome with transplantation, we don't want to confuse the issue in the lack of enough time. We don't talk to you about how excellent the outcome with transplantation is, pediatric and adults. And finally, that our door is open. The Cleveland Clinic has access. Anybody could have access to the Cleveland Clinic, and we're here to host whoever wants to come, patients and physicians, and make a difference in the field. And we thank you all, and I hope that we were able to shed some light on some of your questions and make the topic clear to all of you. Thank you all, and hopefully we will see you in a future time.